Pakistan is not facing a marginal hepatitis problem. It is facing a national public health emergency that has been allowed to grow inside ordinary clinics, blood banks, barbershops, and communities. The World Health Organization's latest 2026 estimate says 12.9 million Pakistanis are living with hepatitis B or C, about 9 million with hepatitis C, and 3.8 million with hepatitis B. More than 48,000 people die from hepatitis-related disease every year, roughly one death every 11 minutes. Pakistan accounts for nearly 1 in 5 hepatitis C infections worldwide, an extraordinary concentration for a country with roughly 3% of humanity. WHO also estimates the program could return $8 in benefit for every dollar invested by 2030. The tragedy is that hepatitis C is both preventable and curable. WHO says modern direct-acting antivirals cure more than 95% of patients, usually through a short oral treatment course. Yet only about 3 in 10 infected Pakistanis know their status. That means millions can carry the virus silently for years while liver scarring progresses towards cirrhosis or liver cancer, and while transmission continues unnoticed. The transmission pattern is especially disturbing because much of it is man-made. WHO estimates around 110,000 new hepatitis C infections occur in Pakistan each year, with 62% linked to unsafe medical injections, including unsafe blood exposure. Pakistan's own strategic framework reports excessive therapeutic injections, syringe reuse, weak infection control systems, and major gaps in blood safety. It estimates that about 8% of healthcare injections are unsafe and notes that roughly 3 million units of blood are transfused annually. This is why the crisis cannot be reduced to individual behavior. A patient who walks into a clinic for treatment should not leave with a blood-borne virus. A child receiving an injection, a woman undergoing a procedure, or a patient needing transfusion should not have to calculate whether the syringe, instrument, or blood bag is safe. Barber shaving, poorly sterilized dental or surgical equipment, informal practitioners, and injection drug use add further routes of exposure. Some statistics require careful interpretation. The often cited 42.7% hepatitis C prevalence in Punjab did not represent the entire province. It came from a multi-center study of people screened at hepatitis prevention and treatment clinics in 2017 and 2018, a population already enriched for risk. That study nevertheless revealed extremely high positivity in some districts and identified injections, barber shaving, dental procedures, surgery, and hospitalization as significant risk factors. Pakistan now has a rare opportunity to reverse the epidemic. In May 2026, the government and WHO launched the Prime Minister's National Program for the Elimination of Hepatitis C in Islamabad, targeting 1.6 million people there before phased national expansion to more than 164 million people. The wider program carries a budget of about 67.77 billion rupees, shared by federal and provincial governments, and offers screening, confirmatory testing, and treatment. WHO modeling suggests successful prevention and treatment could avert hundreds of thousands of deaths and more than 1 million future infections. But screening alone will not eliminate hepatitis if the health system keeps producing new cases. Pakistan has written strategies before. Earlier programs suffered from weak planning, supply disruptions, fragmented surveillance, and poor coordination. So the real test is enforcement. Single-use safe syringes, properly sterilized instruments, regulated blood banks, universal screening standards, hepatitis B vaccination beginning at birth, reliable digital surveillance, transparent procurement, and accountability for unsafe practice. Hepatitis C does not require a scientific miracle. Pakistan already has the diagnostics, medicines, and prevention tools. What it needs is disciplined execution. The measure of success will not be another launch ceremony. It will be fewer infections next year.